So good evening, everybody. Good evening to everybody on the webcast. I'm Councillor Jane Burton. I'm chair of this committee, which is Health, Housing and Adult Social Care Scrutiny Committee. We have today some members of the public to speak, but first of all, I'd like to ask anyone if they have a declaration of interest in tonight's agenda. Anything on the agenda? No, I actually have. I'm a member of the YDRF steering group, which pertains to the item on update on the autism and ADHD health needs assessment and strategy. So there we are. I don't think it's going to stop me doing my work as chair. Okay, and then next on the agenda, we've got the minutes of the 2nd of April 2025. Does everybody agree that these are the fair minutes of the meeting that took place? Very good. Okay, so the minutes are passed and for signing, which I'll do in a minute. So the next item on our agenda is public participation. The first person to speak is Flick Williams, and you're speaking in person, Flick, on agenda item 6. And you know the score. So I'll just let you, do you want a 30-second warning? No, okay.
It's not my intention to detract from the excellent work being done here, but I do have some comments related to the context in which it is taking place. The report touches upon reasons why older people are seeking diagnosis. Going forward, as benefit cuts start to bite and those currently in the support group or the limited capability for work-related activity group within the benefit system find themselves increasingly required to do work search and become subject to greater conditionality, this is only likely to increase. There is a distinct lack of knowledge and understanding about neurodiversity by work coaches. Former specialist disability equality employment advisors have been removed from their client-facing roles in order to cascade specialist knowledge down to work coaches. Evidence would suggest this is having limited success in the climate created by government suggesting disabled claimants are frauds, skivers and shirkers. Those in work coach roles are not immune from this propaganda that with the help of the client media is becoming pervasive in our culture. I quote, "After telling my work coach I'm 8 years on the ADHD waiting list, she said, I don't know why you are bothering as you won't get any medication or PIP. Does that sound like a work coach who understands reasonable adjustment and be able to support her client to obtain them for job applications? When it comes to formal diagnosis, the crux of the issue is this. Children and young people still in education are rightly a priority. But for older adults who went through the education system before even dyslexia was recognised as a barrier to learning, they find themselves in a world of scarce resources where gatekeeping of services and the support they need is increasingly predicated on a formal diagnosis as a way of rationing those resources. The statement in the strategy on the social model is superficial. Genuinely person-centred approaches do not require the proof of formal diagnosis. In fact, previous generations of disability rights campaigners fought against them with slogans such as label jars, not people. Over time, this has shifted in recognition that the support only comes with the label, mirrored by the fight by parents for first statements and now EHCPs. They correctly, in my opinion, see government attempts to restrict their use for SEND pupils as a way of rationing support. The harsh reality is now that many older adults seeking assessment will never reach the top of the waiting list in their lifetimes. As the retirement age rises with the expectation that people must work for longer and the fall in healthy life expectancy that results in more demand for social care, those older adults are likely to be increasingly failed by interaction with services that will not recognise their neurodivergent needs without diagnosis. How to square the circle of meeting the needs of those who are not neurotypical within systems that gatekeep by insisting on formal diagnosis of neurodivergence when the resources for assessment shrink as demand rises. Thank you.
Thank you very much for that. What we will do is pick up those points that you've raised and hopefully action them with the relevant people. Thank you. Right, the next speaker tonight is Roger Tuckett. If you'd like to come up to the speaker. I think you've spoken before, is that right? Yes. So you know the drill. And would you like a warning?
Yes, please.
After, yeah. Yes, we'll be very generous with our time, I'm sure. But if you want to go ahead, thank you. Yes, I think it's on green, isn't it?
It is now.
Yeah.
Okay, ready, steady, go. I've been autistic for just over 3 years. But in fact, a little bit longer. It's affected my life. I thought I had a wonderful career ahead of me, working in as a lawyer, working in a multinational, even working at the European Commission. But my career collapsed, my marriage collapsed, my home I lost my children, I lost my self-respect, I lost my dignity, and for 2 years I lost the will to live. I've managed to recover through a sense of identity of being identified and then diagnosed as autistic. But I'm doing this job, I'm doing here because I want to prevent similar problems happening to other people. I have the skills, I think, of being articulate enough to put forward this case, which many people don't have, but it's my duty and responsibility to do that. I'm pleased with the progress that's been made, which I've been following and so on. Peter Roderick's been doing an excellent job. I think the needs assessment is nearly finished. It's good, it's balanced. It's a shame North Yorkshire didn't do it this way around, of doing the needs assessment first and the strategy afterwards. But anyway, a couple of points to make. One is an absolute howler, which is that slightly over 1% of the population is autistic. I mean, that figure is ages out of date, miles out of date. I mean, the wonderful that North Yorkshire adopted its strategy here about a month or so ago, and the change got made at the very last minute there. The figure in there is 2.6 to 5%. So I do seriously urge people to check that out. It's never been updated for the last 10 years. The other thing is the overlap between ADHD and autism. There's sort of 3 different figures that permeate through the report. One from GPs, secondly from a study, and the GP one's 14%, the other one is 30%, the other was 30 to 70%. It's complicated, but it'd be nice to get clarity on that. I'm speaking mainly about autism rather than ADHD. And really, it's good, I think, to focus on the root cause of autism problems. There's a lot of talk about what I consider secondary issues, sensory issues, reasonable adjustments, routine, special interests, and so on. But I think the primary reason of autism and why my career fell apart, my marriage, everything else fell apart, is we communicate in a different way. And we build relationships in a different way. We do it great between ourselves. It's called the double empathy problem. Why it's called that is, I don't know. And so I think later on, I think I'd hope these things start to emerge. I'm late diagnosed, very late diagnosed. And you notice things like vulnerability and exploitation, principles like alexithymia, interoception, suicidality. I don't see any of these yet in there, and I just hope that all the parties involved in this have an appreciation of this. A big one has been burnout, which knocked me out for 2 years, and again, makes a major impact on careers, jobs, families, relationships, everything. I hope that gets taken account of more as things move forward. Yeah. And 2 other complex things,
30 seconds left, sorry.
Sorry?
Got 30 seconds left.
Oh, blimey, I've got a lot to get through. I think the key thing is this is a York strategy, not a York Council strategy. I think a lot of things go right across with North Yorkshire as well, and I hope there's greater cooperation, particularly as the Mental Health Trust, the Integrated Care Board and the Combined Authority also go across those. I emphasise the real importance of diversity, that there is such a range of people that you cannot no longer get one expert who can talk about one bit of it. You need to get a whole range of that. And specifically with lived experience, I think it's not just experts by experience of suffering, but experts by experience of finding solutions. And that can come from people themselves, carers and allies who have, through their jobs and careers, built up a knowledge of, if you like, how to do that. I think I'll pretty much stop it there. There's various other points I could make, but a quick one then is that the real focus when we come to the strategy and the action plans are measuring outcomes, monitoring them, and addressing accountability.
Okay, thank you very much indeed for your, Councillor Rose, do you have a question?
No, I just wanted to suggest that if you had points, you can email them into us. It's not the strategy ends today. So
I
if you want to
understand.
send everything that you've got through, we can pick that up.
Sorry?
Anything you want to email us that you couldn't say, we can pick that up separately outside of the meeting.
I'll
Yes.
do that. I'll
Do,
follow
do,
it.
do email us, yeah. And we
Thanks very
can
much.
also pass that on as well. Okay, thank you very much for your time. Thank you. Okay, so we're moving on now. Sorry. To consider item 5 on the agenda, which is trauma-informed approaches within Tees, Esk and Wear Valleys NHS Foundation Trust. And I think Martin Liebenberg, who's Care Group Director of Therapies at North Yorkshire and York, Tees, Esk and Wear Valleys and NHS Foundation Trust, is with us today. Hello. It is, yes. I can't get my tongue around tubes, which is tubes. Yes, I could say tube, but I'm finding tubes a bit tricky. So we have the report here that we've all read in advance. And I think perhaps I mean, we can take it as read, but if you'd like to give us a summary or say what you've got, right, please go ahead, and then we'll start asking you questions if that's okay.
Perfect.
Okay.
I was so for those who don't know me, Martin Liebenberg, the Care Club Director of Therapies within North Yorkshire and York, psychologist by background. So my preference is to listen rather than talk, to have conversations rather than present. But having said that, I find myself in this position of having to give a bit of information, which I hopefully will engage in conversation. My musing driving down to York was that I was curious about how trauma-informed does the title Scrutiny Committee feels, because of the kind of the natural kind of emotional response of anxiety and panic about having to present at a scrutiny committee. So my gentle challenge is whether you want to consider calling yourselves a curious inquiry group, but that's not what I'm here for. I suppose, thanks for kind of confirming what's been read. I suppose there's 3 points for me that I want to make before kind of opening up to questions. And I think the 3 key things that I was trying to get through into the paper was the distinction between trauma-informed organisations and care and trauma-informed interventions. Because trauma-informed care isn't an intervention per se. It's a framework, it's an approach, it's a set of principles, it's a way we think about our interventions and how we deliver it, but also about how it gets delivered by an organisation or a system that takes into account and is cognizant of people's kind of trauma experiences and how therefore kind of interventions and experiences may be experienced or felt or delivered. Because the paper kind of focuses, or I was asked to focus on kind of, I suppose, emotional unstable personality disorder, or BPD as it used to be known, still known in some quarters. I didn't kind of over egg the interventional part in the paper, but I think it's useful to mention that from an evidence-based perspective, there's mixed reviews about what is helpful and what is effective, what we know, and that's not just me saying it as a psychologist, but that psychological therapy is the first line of treatment, which I suppose is challenging given resources within kind of mental health trust, not only within our patch, but kind of nationally. What we know is that medication isn't part of the evidence base, except where it's about kind of managing short-term crises. And as is inpatient stays, it's generally not indicated as a treatment of choice. So in that context of thinking about trauma-informed care as a set of principles, as an approach, thinking about what the evidence base is, what feels fairly clear to me is that what is required is a systems-wide and a partnership kind of approach to thinking about how we deliver services, both within our own organization, but also within the geography and the place. And what struck me in doing the report is whilst I feel enthusiastic and positive about some of the changes that's happening, and we've been doing this since 2021 with a kind of a focus around trauma-informed care, is how much work there is to do, and how you change culture and how you change systems to work together in a way that feels trauma-informed and feels kind of viscerally different for service users, but also for staff and the different kind of partnership organizations. And I hope what you notice in our approach is that what we've worked on is to get the structures in place, have the roles in place that can influence the culture around kind of trauma-informed care. And so it's both about kind of thinking about the interventions that we offer, interventional offer, but much more so about the context in which that happens, and whether that feels and is trauma-informed. I wonder if I stop there. I think that's enough. That's enough musings from me. So, but happy to take questions.
Okay, thank you very much. So, members, any questions? Councillor Runciman, and Councillor Fenton, and Councillor Moroney, and Councillor Rose. Thanks.
Thank you, Martin. And if you think I'm looking at my phone, I am, because it's doing an instantaneous transcription for me because I've got impaired hearing. I'm very interested in the changeover. I think it's subtle, but it's very important. And I found the report that you'd written extremely interesting. But I wondered if you're doing any longitudinal work to make sure that the effect on the recipient is lasting.
Yeah.
Rather than just at the time that you're doing it.
Yeah.
Because that would be the ideal, wouldn't it, if you go back afterwards? So I wonder if you could just comment on that for me.
Yeah. I suppose there's two kind of comments in my mind. One is about what we would do as kind of, I suppose, part of due process, normal process in terms of follow-up. And I suppose there's the idea that if we do a piece of intervention, it's that discharges are planned, and that it's not about a sudden end, but it's thinking about and speaking from my own profession, the idea of a check in a 3 months' time, and a 6 months' time, and a year's time, is something that is possible and can be done. I suppose my caveat, and this is where transparency and honesty come in as part of a trauma-informed, is that often demand kind of drowns that out. And I think then it becomes reliant on people returning or coming back or being re-referred into systems. And I suppose that's the bit to kind of really think about, is that if you really want to change something, how do you kind of build in those kind of checks, and that, as you said, longitudinal kind of follow-ups, which I suppose is in some respects not much difference, or some of the kind of, how do you do preventative work, and so kind of preventing relapse prevention. Yeah.
Yeah, sure. Yeah.
So when somebody is discharged, do they have to come back or to you plurally, or do you give them strategies? Have you built in strategies for them to be able to empower themselves to deal with a certain level of stress or trauma that they may be under?
Yeah, absolutely the latter. So, so if I think about, and apologies if I locate quite a lot on psychology, but it's just my field. So if I think about when somebody goes through some cognitive behavioral therapy, what the last few sessions always focus on is something called relapse prevention. And those are the exact kind of strategies that you talk about. Is that, so when you find yourself in a position where suddenly, I don't know, thoughts can return or kind of behaviors return, what are some of the skills that you can use? And you'll notice also that within kind of EUPD, a lot of the approaches are skills based. And so this idea that you know that you're not reliant or dependent on another person to support you with that. although that's also important, but it's about your ability to kind of implement those skills yourself. That absolutely is part of that. But also, I suppose, just in terms of the former kind of bit as well, is we try and make it easy, so you don't have to kind of go through a GP in the first kind of year. You can refer yourself into the team that you come from. So that's to make that a little bit easier. But it's absolutely intention to give the skills for people to manage their own relapse. So.
Thank you. Councillor Fenton.
Thank you, Chair, and thank you for the report. You mentioned TUV is part of a system. Obviously, you do not exist in isolation. So I just wondered if you could tell us a bit more about what you see across the broader sort of health and social care landscape in terms of, obviously, some of the residents who you see will have been on a journey through primary care and accessing other services. What, in developing this approach, what have you seen in terms of experiences elsewhere that you've identified do need, or that those colleagues could benefit from being aware of your approach and potentially following a similar approach? And what role can and are you taking in terms of system leadership?
Yeah, good question. I think sometimes I think luck is an interesting concept, but we were quite lucky quite early in the process to obtain some funds through the community transformation initiatives to appoint two dedicated trauma-informed care leads, one who co-authored this with me, Amanda Hall, who is also doing work with York City Council. And I suppose what was quite interesting is, because in some respects they didn't have a job remit. The remit was go find out, go work out where trauma-informed care kind of exists in the system, and who are your early adopters, who are the people who are kind of interested and keen. And I suppose that is interesting to note. And I suppose if I kind of, from a trajectory kind of perspective, the early adopters around this, social care, police, the ambulance service, acute less so. We've struggled to engage with acute, and then interestingly, mental health a little bit later down the line. But I suppose the commonality of what we notice is systems under pressure. And what does it feel like for systems who are under significant pressures for a variety of reasons? And how I mean, one of the things we talk about in trauma-informed care is about how you are able to retain thinking within a system, as opposed to being overwhelmed by feelings and by overwhelmed by what's going on around you. So that kind of ability to step back, reflect, think, implement. And I suspect that that's the thing that we probably notice the most, is that systems under pressure are the ones who struggle most with thinking and reflecting. And so some of the work that we do within being a kind of systems partner is that kind of reflective supervision groups, that spaces to kind of think about, well, what's going on here, not only from a trauma perspective, but also about, I suppose, how organizations traumatized their workforce and each other, because it's what we do. Is if we're under pressure, we attack, we don't cooperate, we don't kind of think about kind of partnership works, and you know, I'd like to kind of think that trauma-informed care is one of the approaches that goes, stop, let's think, let's work this together as a partnership, as opposed to being in competition. I hope I answered some of your questions. It was a good question. So.
Okay, thank you. Councillor Moroney.
Thank you, Chair. I wondered if you could briefly help us by comparing and contrasting positive risk-taking models with trauma-informed care, and whether you could kindly highlight what might potentially be lost by the switch and what you think the main goals of the new model would be.
Yeah,
Thank you.
Yeah, that's helpful. So I think that goes back to my first point, in thinking about trauma-informed care as a framework, as opposed to an intervention itself. Now, BPD protocols, I think they were a clumsy approach, and I use that word very kind of carefully, but it was a clumsy approach to try and translate what I suppose the evidence base would tell us is helpful and useful in thinking about how to help people who are feeling distressed by something like emotionally kind of unstable personality disorder. And so the kind of key components around things like consistency of approach, around healthy boundaries, about not having or offering opportunity for splitting, good, bad. That's a good person, that's bad service. It's to allow for that. I think where it became very clumsy was this kind of overemphasis on capacity and risk taking, and this idea that ultimately a person can make their own decisions if they have capacity. And we had the conversation a bit earlier about how tricky capacity is as a concept in terms of what it applies to. But that you do it in a different way. So the principle of how you keep boundaries, the principles of how you negotiate capacity, the principle of how you negotiate, I suppose, support is still the same, but you do it in a different way. And so I think that's the added bit. And the added bit is that you do it in a way that you hold in mind that most people with a personality disorder, particularly in EUPD, will have a trauma history. Will probably have had at least 2, if not 3, if not 4 kind of childhood adverse events. And so therefore your relationship with the person who comes into your service needs to hold that in mind. And so the attachment that they form with you or not form with you is informed by that. And so I think BPD protocols overemphasize this idea of strict boundaries, strict kind of decision-making lies with you, not with us. And what trauma-informed care, I think, helps us do is saying, yes, of course, that's true. The principles are true, but we do it in a way that feels supportive and compassionate, as opposed to rejecting and abandoning. I think that's the biggest difference for me. So,
Forgive me, do you think we're in danger of losing anything by moving from the old model?
I don't think
Thank
we
you.
are.
That's
I
a
don't think we
very
are.
definitive answer.
Yeah.
Thank you. And if you try to define the main goal, the main prize here,
Oh. I hedge my money on avoiding re-traumatization. I think there's your prize. So if we can avoid in what we are doing to not re-traumatize people because of their experiences, we do well. So, yeah.
Okay, thank you. So Councillor Rose.
Thanks. I've got quite a lot, so I'll keep it short, and then you can cycle back to me or whatever you want to do with that.
We're doing quite well for time, so don't worry too
So
much.
far. Yeah, I think the obviously this is a much better way of doing things. I think that from what I can see, these are steps in the right direction. All the words in the reports are about improvements. I think they're all really good. But specifically, how is improvement being measured? Obviously, outcomes building trust with the organisation and across the system is key. But I'm conscious of some specific things. So reports of victim blaming, some reports of aggression towards those who are self-harming or experiencing suicidal thoughts. So in Health Watch reports, we had someone calling about ODing who was asked why they didn't take even more. Not exactly healthy stories. And I think we've all of us who deal with casework, you hear more stories. How can you evidence it's already improving? How do we continue to evidence it going forward?
I suppose I think there's 2 different. You do well on time, but so you might keep the questions short, but my answers are often very meandering. So it's so apologies. It's I suppose I'm thinking about one of the things I try to describe in here is that this is a long-term process, and how do you turn around if you just look at an organisation like 2 with 8,000 staff members? A system that probably is tens of thousands of systems, of 1,000 people. How do you get them on board in terms of culturally thinking different about the work that they've been doing? And you're right, I think there's some obvious outcomes, clinical outcomes, engagement, patient experience report, what gets fed back. And I suppose we see some of that, and I think I kind of describe in my report is that some of that, you know, how we use some of our, for example, our complex emotional needs practitioners is we send them into formulation meetings, we send them to discharge meetings, and their job is to challenge, their job is to kind of make sure that that decisions are not being made that's not trauma informed, and so it's kind of evidence are starting to emerge from that narrative evidence that says, people are reflecting, they're thinking, they're changing their approach. None of that is going to stop in the short term some of the stuff that you described there. And I think that it's the how do we approach and how do we think about it, and so when those incidents gets reported, I think what a trauma-informed approach will tell you, what you don't do is you defend yourself against it. You don't use it as critique and find a kind of a defensive response to it. It's the how do you engage with it, and how do you work it through, and how do you pick it up with that team, that person, that part of the system that goes, you may want to think differently about that. And I wonder whether there's a way in which we can work with that. And so I couldn't give you the assurance that none of that stuff happens, because you know that wouldn't be true. What I can give you assurance around is that I think we're working very hard at making sure that we've got the systems and structures in place to build, to scaffold, to expand, and to I was about to use the word infiltrate, which is probably completely the wrong word. I think you know what I mean in terms of how we permeate is a better word, permeate kind of the system to take a much more kind of trauma approach to it.
I think that's a good response, but I guess trying to pin you down slightly on, you can't give assurances now, but there needs to be the ability to give those measurable assurances over time that, I guess, specifically add those adverse impact events, those negative stories, and you mentioned re-traumatizing earlier. I guess the rate of re-traumatizing is reducing over time, but is that measurable? Is there any way of getting objectivity out of that?
Yeah, you ask a challenging question, and you know, some of those things are I think measurable. I think as I said, complaints into the service. I think that does it go down? Does it go up? I think that's one way of doing it. I'd like to believe, and I think this is the clinician in me, that your clinical outcomes is the one that will tell you the most, that will tell you the best story in terms of whether this is having an impact or not. And I'll declare my slight aversion to organisations that declare themselves to be trauma informed, because that feels like a kite mark or a stamp of honour, which kind of misses the point for me that being trauma informed is an ever evolving, ever growing, ever kind of challenging thing, that you never get to the point where you're fully trauma informed. So I think you're always in the process of becoming. So I don't know whether I evaded your pinning down again.
Yeah, I mean you did, but I appreciate. I mean, and the answers it betrays a level of honesty, I think, which is that there are things that are quite difficult to measure, and it doesn't mean it's not worth doing if you can't evidence it. A similar point around comorbidities, if you like. I think it's obviously very rare for trauma to exist in isolation. There's different things, whether it's other mental health challenges or substance misuse, etc. I just want to know what's taking place at the moment and what we should be doing more of on that intersectional piece. So, for example, apparently police are being told that CHUV won't take in people with substance misuse issues. Apparently community mental health team won't work with people while they're dealing with addiction. That feels very counterproductive to me. So how are we improving on that under the new framework?
We have a very, very active dual diagnosis network, which is chaired by a co-psychologist colleague of mine. And it's interesting, we did a recent presentation at the North Yorkshire Partnership Board. And one of the things that kind of came out of that was a joint piece of work with Recovery Yorkshire, which is a Harrogate-based, it's a recovery for Connections, that's what they're called, Connections, which is a recovery-based one. And that narrative around can't take you because you've got substance use, we're absolutely putting an end to that, because got to see substance misuse as a symptom of distress, and this idea that you can't engage in mental health services because you use substances is a nonsense. Now, are some organisations better at dealing with that bit first rather than a mental health organisation? Perhaps, and that's why we've got good kind of services within the service within the system who can support that work. But that's not to an exclusion. It's kind of working out how do you scaffold an intervention sometimes, but it's also recognized that sometimes you need the psychological or the mental health intervention first to give you the coping strategies, the skills that you need in order to stop using alcohol in a way that supports, or drugs or whatever, in a way that supports that. So I do want to give you assurance that that's not an approach that is signed up for or agreed around, and we are doing active work around that. It might be interesting to kind of pull some of that kind of dual diagnosis work into this committee at some point, because I did good work. It's an active network across the system. We can give you a more eloquent answer as well, but yeah.
Okay. You've got another one? Okay, well, shall we let Councillor Wilson have a go, and then we'll come back to you. I've got some as well, so but it's good.
Thanks, Chair. And thank you for your report. And it's been really interesting to hear you speak so far. And I noticed that one of the things you were saying is that it's really hard for acute services to get them to engage because they're kind of under siege, and having that space and time to reflect is really hard. One of the pieces that we've been emailed prior to this is people's responses to Healthwatch about how they found the crisis line. And I did, as you were saying that, think, oh, I wonder if that's why that is particularly tricky, because you've got those people who are actually struggling on the front line of talking to people. But I'm really aware that the crisis line is a time where re-traumatizing people and people having traumatic experiences, phoning them is quite challenging. And I wondered if you could speak a bit more about the crisis line specifically.
Not out of a great sense of knowledge in terms of what work has already gone into the crisis line in terms of a trauma-informed training, because in some respects we're rolling out the training at the moment in a who's interested. The exception being we've in the last year got ourselves onto the nurse preceptorship training as part of their induction. So as part of the induction, they do a day on trauma-informed care as a kind of an introduction to that. Yeah, I struggle to kind of give you a sense of saying that I don't know how many people from the crisis line, for example, have either kind of had training in trauma-informed care. They'll be aware of it, and we host 6 monthly, I suppose, kind of trust-wide events, and our next one's coming up in June, where everybody in the organisation is invited to that. But I have a feeling it's one of those where we probably need a slightly more targeted approach in terms of reflective supervision, reflective groups, which takes time and is time out of kind of people's diary. But I think it's also about that kind of circular loop around when we get feedback, we pick it up, and yeah. So it's a slightly vague answer, as opposed to say, kind of saying, yeah, there's many parts of our system, but yes.
Councillor Rose, do you want to ask?
Chip away another couple before you've got some. Yeah, you mentioned about the challenges of re-traumatizing. I guess there's a specific question for me of those whose trauma comes from the place they have to go back to for support. So, you know, moving away from Shuva as an example, but people who had traumatic births, but they have to go back, or people who had traumatic response for vaccinations, but need to go for other health support at the same place. How does the trauma-informed approach change how people are sensitive to that, or what behaviours can they shift toward?
So I suppose one of the things you would build in is questions in your kind of initial assessments, your initial kind of engagement around, are there particular places to avoid? Because, you know, in some respects our challenges, we are large geography, but that's also our benefit, because, you know, we don't have to see people in particular places, we can see them elsewhere. Now, it's whether building and space is the place or whether it's organisation is the place. Because if it's building and space, that's a reasonably easy one to go, right, we won't do work there, we'll do it over there. If it's the organisation that feels by association the one, I think there is an honest conversation around, does it feel like it's something we can mitigate, hold, be supportive, be compassionate around? Is there another space that or another organisation that would feel less traumatizing? And so that's about introducing choice. It's about having honest conversations around, will this feel unhelpful? And if so, what are our options around that? And so I think that's what trauma-informed care would suggest. It wouldn't suggest a magical solution. It would say, have the conversation in an honest, transparent, compassionate, and I suppose supportive way about working out what's the best place, what intervention is the best intervention if a previous one has felt. Sometimes it's about fit. Sometimes it's about, the clinician that you work with or the group of clinicians you work with. I always advocate within, again, a psychology framework, you've got to shop around a little bit if you can. And that's not always possible within kind of statutory services. But a second time around with a different person may feel different. So explore it. So,
Thank you. And yeah, I think one of the challenges, I guess, is across the care system, in health in general, organisations can sometimes be quite bad at acknowledging faults, not necessarily taking culpability for something, but just acknowledging where that lies. So I think that's something that we all partners can.
Can I come back on that? Because I think you're right, because I think what that invites you to do is go into this attack defend mode. And I think that's the bit again, when you introduce thinking into the system, you can step away from attack defend and you can get into discussion and collaboration. And it's the acknowledgement of what presses your button and puts you into kind of attack mode, and how you step away from that. And I think it's a challenge for many people, not only mental health professionals, but also kind of people in everyone. But it's about how you avoid attack defend in those discussions.
And that's the other side of the fence as well, as a patient. If you feel like you're being victim blamed or it's your fault that something bad happened to you, then that's never going to help open you up and work with the people that are there. You also mentioned, I guess, traumatized workers as a kind of concept. I think particularly in some of these healthcare scenarios and the situation as it is right now, that is a big problem and a big challenge in how to meet other people's needs while you also have to meet your own needs. What can we as employers do in this space? How can we handle our own staff's traumas better? What advice would you give, or what are you guys doing with your own team?
I suppose we try and tackle it at a different. I'll start with us and then think about it more broad. I think this, if you look at the staff wellbeing literature, there's just two broad approaches, and I think they go alongside each other as opposed to in opposition to each other. One is a kind of a resilience building, recuperation kind of space, and I know that's been maligned in the press, so kind of thinking about yoga groups and retreats and massages at the desk, and I don't think any statutory organisation does any of that. That's the business of kind of private one, but it's the principle is about how you provide space for people to recover and build resilience. Perhaps arguably the more effective one alongside that is about how you address root causes. And root causes at the moment is overwork, is busyness, it's being competition. And it's interesting, it's something when you look at I suppose kind of the staff surveys, the national staff surveys that comes through, there's a core theme there about being traumatized by overwork and capacity. And so, unless we address that, this is never going to feel, this will in some respects support you, but it will never address it. And so I think it's and I will say this because this is my kind of professional bias, I think the more opportunity you give people to reflect and think and process their experiences, the better chance you have in terms of them building the capacity to deal with overwork, but equally to build their resilience and have restorative experiences. So I think there's the restorative element to it, and then there's the how do we deal with the root cause around that. So yeah.
Okay, Councillor Moroney, would you like?
Thank you, Chair. I think you're about 4 years into the process of building this trauma-informed structure. Okay, so slightly odd question. How many marks out of 10 would you give yourself so far?
Oh, Two of you wouldn't nail him. Where would I put myself? Where would I put this organisation? I'm naturally quite a low marker because you know, if you come to a recruitment interview with me, you'll never get a 5 out of 5. You'll always get a 4. So 4 is pretty damn good. But I probably would put as a 3.5, 4 out of 10. Is probably where I think we are. That's yeah, and that's not undermining any of the work we've done. But I think it's indicating the enormity of the task and the scale of the task. So
For what it's worth, I'm delighted to hear you giving a figure in that area. So thank you for that honesty. If we were to invite you back, say in 12 months' time, do you think you'd be in a position to describe measurable improvements?
yeah, what I will be able to describe, and this is the next piece of work that we're doing. I mentioned in my report we've pulled in Katie Taunt, who's kind of a national guru around trauma film care. She's done quite a lot of work within the Humber North Yorkshire kind of system. So if you ever get an opportunity, they are some kind of what they call training course for senior leaders to go do 2 days with Katie Taunt. She's brilliant, and what she's helping us with next is about how we the Humber North Yorkshire kind of ICB got some money within a CAMS context to develop a trauma-informed toolkit, and that's the one I reference in the paper. And that toolkit is about helping teams, services, organizations, I suppose kind of just sense check where they're at in terms of trauma-informed care and then work out what the action plans are. And what we're doing next, and that's the focus around our June event, is we're starting to pull in teams and services to start using the toolkit. And I think the toolkit will give us some baseline stuff. And then once you've got some baseline stuff, you can start doing some measurable things. And what we're wanting to do is not only focus on clinical services, but also corporate services. So thinking about our finance team, thinking about our HR teams, our recruitment teams, and how do they become trauma informed and the work that they do. So what I'm hoping that in 12 months' time we'll see is how that toolkit is being applied and what are we learning from it. So,
okay. So I'm just going to step in and use my chair's prerogative now. So we were sent some data that was very confidential from Health Watch that was showing a less than good experience of mental health patients, and quite recently. I can see that this is a really amazing approach, very informed and will be transformative. And I think it's very good. But do you think there's a worry that you're leading this from the top and that the people lower down who are coming into contact with people who maybe are getting, for whatever reason, sort of compassion fatigue, and that I mean, we know about the problems within the healthcare system, that there are too few people doing the jobs, and the demand on the services, so that patients who are coming through to, for example, the crisis line, are really not getting the service that they expect. Now, we're not saying that's the case for everybody, but there are examples of this in the report that we've seen. Unfortunately, we can't share that because it is confidential. And that's kind of unfortunate, but I'm sure you understand why. And one thing I wondered, is there's a few thoughts that I've had about this, is, more, there's a culture, I think, sometimes that builds up in systems and in different places that's not at all helpful, very negative. So that needs changing. And it's like you say, it's not going to change overnight. But I wonder if, that you could work with Health Watch and work with them and find out sort of what percentage of patients are not having good experiences, because what you have put into place is so very positive. But if they're not getting that therapy or care
Yeah.
or treatment or whatever, then they're not benefiting
Yeah.
from your very excellent work.
Yeah.
That's what's worrying me about
Yeah.
this.
Yeah. There's a few different responses to that. It's I suppose I'm curious about whether you've seen the report from Health Watch that describes the work around within community transformation, because that's a kind of really kind of if not, I can forward it.
Yes.
If it's easiest to do, to send to James. So my only qualification, I can't remember whether it's a York Health Watch or a North Yorkshire Health Watch report, but nevertheless, I think it's important to see, because I suppose what that described is the impact of things like introducing the mental health first practitioners into GP surgeries, and the positive impact of that, the introduction of this work, the introduction of complex emotional need practitioners, and so recognition of some of that impact. And I think my caution is always that we hold the balance picture in mind, but the balance picture also includes the very negative stuff, and how do we address and kind of focus on that? Because you're absolutely right. I think what we're trying to make sure we do is that it's not a top-down thing, because that's not trauma-informed. I mean, there needs to be drivers, but there needs to be people within this system. And I think the bit, go back to kind of impact, I think the bit where we see most impact at the moment is where you have a complex emotional need practitioner go into an MDT discussion and change the outcome. And there's a kind of a visceral sense of, oh, we hadn't thought about that, or that feels different. And I think that's the stuff where you start seeing organic change happening.
Yeah.
Because I think this is an organic change process, as opposed to something that you know, day X we are not trauma informed and day Y we are. That's never going to happen.
Absolutely.
But it's about how we hold both of those in mind.
Yeah.
So I think, again, the bit that I do want to assure around is that I think we're thinking very hard about how all layers are involved in that, and that's not a top-down one.
Yeah.
But of course, and one of the things we made sure is that the care group board for North Yorkshire and York has also received the training, and
Yes.
so that's the lead by example stuff, but it's also trauma informed is about at all levels. So,
Yeah. It's again, as you say, it's changing the culture over time. So, has anybody got any other questions? Yes, Councillor Rose.
I've got 3 left, so it's all right. It's not too bad. You mentioned about trauma informed being about all levels and all partners as well. I'm curious to get your take, given everyone's moving at different paces on this. It is something that everyone's got some training on and a bit more knowledge of.
Yeah.
Your experience of partners, other healthcare organisations, the council, are we practicing similarly? Are we using the same language as each other? To what extent are we aligned, and to what extent is there friction between the different practices on the approach?
No, I think what's helpful is that there's quite a lot of uniformity around the language of trauma-informed care. I think there might be nuances around some of the 6 principles, but they are broadly the same principles. And so there's very little kind of, I suppose, room to deviate from the core principles of trauma-informed care. Go back to my kind of point about the lack of having had 2 dedicated practitioners. They worked into a lot of the parts of the system. So some of the contents and I suppose the framing of trauma-informed care would be similar. And of course, individuals are individuals and humans are humans, and therefore the bits that you kind of take out of it for you might be different, but as an approach, it's pretty consistent worldwide. It's
To what extent do you think there is merit in this going beyond healthcare and care organisations? I'm thinking a lot of us who knock on people's doors as residents or have casework or deal with things. Obviously us as councillors, but there are a lot of other people in similar situations who just engage a lot of charity volunteers of varying types. How much merit is there in us looking beyond the traditional places to try and be more trauma informed?
So I'll refer you to north of the border, Scotland, had and this is going back a good 10 years now, a really, really ambitious ambition that trauma-informed care ought to be rolled out across the entire population. And so this idea that at levels, because somebody who, for argument's sake, is, I don't know, a receptionist in a building, require a level of trauma-informed kind of, so in how I greet a person, how I engage with them, how you can apply trauma-informed principles in that, which is different from somebody who perhaps needs to deliver intervention at the other kind of the side of it. I don't know how far they got, because it's a massive ambition, but this idea that there's merit for every person to be trauma informed and how we engage with each other, I would wholeheartedly kind of support, because I think there is. I mean, if we go back to intersectionality, if we think about racism, if you think about prejudice, if you think about discrimination, if you think about how we think about others, trauma-informed principles will have something to say about that. So it's not surprising that kind of gender differences or kind of sexuality or otherness is part of the principles of. So it's certainly not a healthcare thing. I think it's and it's interesting. It's the other thing we're quite careful with in TÜV is we don't want it to be seen as a psychologist thing, because that's the other thing that people sometimes do. They kind of put it within psychology. It's not. It absolutely has to belong with everybody. So we're very careful to have a lived experience. Can people work alongside us? Our peer support workers work alongside us on the steering group from top, but also driving it down. So long answer to say.
No, it's a good answer. And I think, we know the resource limitations, but for me, if everybody was trauma informed, if everybody had first aid training, and if everyone had zero suicide training, that would take a lot of pressure out of the system in general. So, personally, I think there's merit in that. My last question is, on our list of future items for this committee tonight, we've got York as a trauma-informed city as one of the things for the future. And I'm just curious to get your take on what we should be looking at as part of that. Is there anything specific you think we should be trying to get a report on or think about as at a city level rather than as a council?
I'll throw the challenge back at you. I wonder whether you can design some outcomes in terms of how will you know when you're down the line. I'm not too sure who around the room is involved in some of the initial kind of scoping around training. Amanda Hall, who tried to take a sneaky peek at the attendance list to see who she has spoken to. And I think there's a small overlap, but I think it's about working out who in the system is interested in it, who's buying into it. I'd argue that your first step is making sure that people have knowledge. So, and I think that's your starting point, that people understand what trauma-informed organizations mean, and then work out, well, what we want to do differently. Perhaps change the name of this committee back to my kind of starting point. But I think it's often language is powerful, and language is powerful in trauma, and it's about how we engage. So, yeah.
Thank you.
Thank you very much, Councillor Baxter. I think we're going to wind up. Stop that.
Thank you, Chair. Just sort of touching on something that Councillor Rose brought up about the different levels of training that people receive within healthcare. Are you able to, don't know if you know sort of the operational details, but go into that a little bit more? I've previously worked as a carer in the city and for the council, and I don't recall doing any kind of that sort of training, and I just wonder sort of to what level it varies, because obviously as a carer you are sort of dealing with people who may have trauma. And then my other question is sort of around the other organisations that you mentioned that have sort of embraced or taken on the trauma-informed training, and how they are monitoring that within their organisations, and how that's actually working out. I've seen stuff on a slightly different topic about the Ask Angela project, that's been going on, and actually how it's all well and good sticking up a poster saying ask for Angela, but actually it's not really working, and pubs aren't really taking it up, and they're just sort of ticking a box. So I appreciate the two sort of separate topics, but if you can elaborate, that'd be great.
I will try my best. Because I think there's something about thinking about when something is not working, how do we challenge that, and how do we change that? So I think what a trauma-informed approach would say is, again, it's not about attacking, but it's about being curious about this. And so again, go back to measure of success. One of the things that I'd want to see is, but are people getting better at asking curious questions? Are they curious about what's going on? Because if you're curious about something, you're less likely to judge it, and you're more likely to be interested in kind of understanding it. So, at its most stripped down version, what you'd want somebody with trauma-informed care to kind of know is, what is trauma? And what is its impact? And what are the kinds of traumas that we're talking about? I think, again, we have moved miles down the road from trauma was, if I think about when I trained as a psychologist, which is many, many years ago, trauma was a life-threatening thing. Road accident, terrorism stuff. We've moved on, and that kind of idea that trauma is something that challenges your sense of self in a way that makes you feel unsafe is a good starting point in trying to describe what that feels like, because that helps inform how we interact with each other. The principles of trauma-informed care is an absolute must. So there's kind of 6 principles that I describe in there. And then thinking about, well, what does it mean for me in my job role and my team and my service is your next step. It's quite a big jump up from there then to start thinking about, I suppose, etiologies of diseases, of disorders, thinking about different kind of trauma interventions, and I think for most people outside of the kind of the health sector, probably wouldn't need that. But that kind of what I've just described there is for me an absolute minimum. But it's also, and I'm trying to tie it into your second point about, I don't quite know what Ask Angela is, but it's something about, if that creates a response or reaction to you that doesn't invite curiosity or doesn't foster cooperation, possibly the wrong approach, possibly could be a better way of doing it. Don't know the answer to that. Yeah.
Just Ask Angela is a system where I think if you're in a bar or out somewhere,
Okay.
and you are feeling in danger,
Okay.
by a partner or someone that you're with, you can ask for Angela.
Gotcha.
I was at the racecourse actually, where there's a part of my ward, and we were investigating their licensing, and we went round to many of the bars on a race day, and we're asking the bar staff, and they knew about it. They were all briefed on it, so that when somebody came up to them and said, "Where's Angela?" They didn't say,
Right.
"I've no idea what you're talking about. They're not here," or something like that. But I was really quite impressed that that everyone seemed really from each level. That so they have very good training at every level. I can recommend it. Yes, that's what that is. So.
But I suppose that describes it beautifully, how, in some kind of scenarios, environments, it feels like actually that's working and it's helpful. Other environments, it feels like it's not working, it's not making a difference. So,
however, they had a very specific, they were very tight on doing these things and making sure that they absolutely were, they had a book, training book for all staff to read before they were able to work. Now, the point is, do all places with a license do that?
No.
Probably not. And it's like with the trauma involved care. It will, it's going to take time to move out.
Yeah.
I suppose I'm looking for ways to speed it up for you and for everyone, because I think it will be a better place for it, for more understanding and kindness as well, in a way, because in a way that's what it is. Maybe I'm being a bit simplistic, but that's how I can see it working. But
way to speed it up, ask curious questions of everybody you come across in the health sector, in terms of what do they know about trauma-informed care, and if they don't, how can they go and find out?
Yes, yeah.
So
well, I mean, maybe we could invite you back in a year and see how things are going. I think if I think we'd be all keen to do that.
Happy to do
Yeah,
that.
that would be lovely.
Yeah.
And I can't thank you enough for your time and your patience in answering all our questions.
Yeah,
It's-
having said that I don't like talking, I clearly do. So, so thank you.
I hope that we haven't scrutinised you too badly.
I feel intact, so it's we're good. So,
Gently. Yeah. Thank you very much. Thank you. Hey, so thanks indeed. Right, we're going to now move on to item 6 on the agenda, which is an update on the Autism and ADHD Health Needs Assessment and Strategy 2025 to 2030. And we have joining us at the table today, we have Peter Roderick, who's Director of Public Health for CEO of the City of York Council. Jodie Farhagson, Head of Public Health, the Healthy Child Service. Anna Ikwe, thank you, sorry. Head of Operations and Partnerships from Learning Disability, PFA and Autism. Victoria Coyle, Head of Integrated SEND, Special Educational Needs. Yep. Angie Walker, Senior Programme Manager of Mental Health Prevention Partnership, NHS Humber and North Yorkshire Integrated Care Board, ICB. And Kirsty Kitching, NHS Humber and North Yorkshire Integrated Care Board. So welcome all today to today's Health, Housing and Adult Social Care Scrutiny Committee. So we've all had a chance to look through the draft report, and I don't know if who specifically, if anyone is would like to speak to us about this. I can see Peter Roderick raising his hand.
Thank you, Chair. Yeah, if that's okay, I'll kick the conversation off, councillors, and thank you for having us this evening. We've brought a whole crew, I think this is called.
Yes,
so really want to thank all my colleagues for coming. I do also want to thank Roger and Flick, who've already contributed on the item this evening. And I think there's something about what Roger said about this being a city strategy, not a council strategy, which is important. And though we represent more than just the council in terms of partners, I'd hope that behind this work lies much more than the NHS and the council that you see before you today, and an awful lot of work with communities to try and get this right. And we're not there yet, but hopefully this is an important staging post along the way. And I will take a few minutes, if you don't mind, just to outline the context, because I think it's just important to almost tell the story a little bit about why we've got to where we got to, for the benefit as well of anyone that's watching, as well as I know committee members have followed this closely for a little while. So we came to the committee in November with a health needs assessment covering the needs of autistic people and those with ADHD in York. It was a piece of work that was in draft form at the time, and we had some public comments and we had some scrutiny comments that we've now taken into account. And what you've got before you in the blue document is essentially what we hope is a bit of a pre-publication draft. We're hoping that this will be able to be put onto the council's Health York website and published. What the health needs assessment has done is to try and look at some of the background data and some of the evidence that we needed when we were writing the strategy. And we appreciate, I think when we came in November, there were certain elements of some of the language and certain elements of some of the contents that we weren't quite yet there with. I'm really pleased to say, I mean, I'm sure we're not 100% there yet, but I'm really pleased to say I think we've come on quite a bit. I'm very grateful that in November, we had Dr. Laura Fox from the University of York come to speak about some of the things that she wanted to see improving, and very kindly offered to volunteer a little bit of time to work with us. So actually this health needs assessment has had quite a lot of input from Laura and from some other stakeholders as well. So we've updated a lot of the language within it. We've updated some of the evidence and tried to get to a really good summary of what some of the needs are. You'll find on the 4th page of the needs assessment, a table which just describes some of those issues, and I won't go through in detail, but I think as Roger has already mentioned, actually, there is something about understanding what needs within our population and what sort of proportion of the population is autistic or lives with ADHD. That's not an exact science. And I think one of the things that needs assessment definitely demonstrates is you look into the GP data, which is generally people who have had a diagnosis by a professional and therefore they've been given some kind of code on a system. That is a substantial underrepresentation of the number of people who are autistic, the number of people with ADHD in York, and therefore getting to the true amount is actually quite hard. There are, particularly with autism, it does seem that some of the things that public health would go to in the almost the official versions of the truth are probably slightly behind. So the 1% figure actually comes from 3 or 4 sources. It's what the WHO quotes globally. It's what the NICE guidance says is an estimate of the current prevalence, and it's what the Global Burden of Disease from the Lancet Journal says. However, I absolutely admit that there are a number of quite sort of convincing studies which do suggest for autism, we probably are looking above the 2% mark. And if so, the numbers of people in GP registers in York is a lot fewer than actually would be actually out there in the population. Just to clarify that point. But I think some other things from the needs assessment to pick out, the real male to female diagnosis ratios that we see, much more likely to be getting a diagnosis as a male in both autism and ADHD. Some of the data that we pulled through, which is probably well known to the public in York around waiting times, and I think it's fair to say for both CAMS for an assessment for children and adolescents and for the retreat for an assessment for adults, you are looking at substantial number of months and into the years, and that's well publicised, but we've laid out the most current position. It also talks about the health issues and some of the physical and mental health needs that autistic people and people with ADHD face. In particular, I draw people's attention to just the burden of mental illness in people who are neurodiverse in the city, and the burden of a number of physical illnesses. As the report makes clear, there is absolutely no evidence that there's anything inherent with being autistic and having ADHD that might make you more likely to have a physical or a mental health issue. But it seems that in general, the way society has responded to these issues and some of the ways in which we don't adjust probably means that people are not receiving access to services, or they might find stigma or discrimination or bias. A number of different factors might mean that their mental health really suffers or their physical health really suffers. So that's the health needs assessment and where we've got to with that. From that, what we've done is formed a number of different opportunities for people to help us produce this yellow document, which is the draft strategy. We are not at the same sort of almost finished stage with the strategy. We are at an intermediate stage. And so all comments very welcome, obviously, from committee and from the public and from the community to make sure that we keep on getting this right. But what we have done so far, we've formed a steering group which has a number of different representatives on from lots of different agencies. It does have people with lived experience on, but I would be really plain that actually one thing we'd be challenged on recently as a steering group is, do we have enough lived experience voices, including people who aren't necessarily linked to an organisation but would just like to represent the neurodiverse community. So we've taken a step to do that in the last week, and we've asked for 4 additional lived experience representatives to join our group. So hopefully we will keep on including that voice. But we have formed that group. It's been going now for about 6 months, and we've been meeting to draw together what you have in the yellow document. Part of the process has been the feedback that actually sometimes when you write a strategy, getting 100 people in a room and flip charts and sticky notes really works. Actually, for this particular strategy, that wasn't the best way. There were a lot of existing groups, peer support groups, charities, boards, partnerships that already exist. And the challenge, I guess, we felt was to go out to those groups to have a conversation. So we set 3 conversation questions, which I think the committee saw in November, and we took them out to the groups and have brought back the feedback from those groups. into the course of the strategy. From this point, now we've got something down on paper, we've got some more sort of workshops planned that are a bit more open, and a formal public consultation. And colleague Jodie, I think, may sort of cover a bit of the details there, but I just wanted to mention what happens next after this. And we're hoping that this comes back probably through the council's executive, because there is something about the statutory duty to respond to the National Autism Strategy does fall on both council and the Integrated Care Board. So we would like actually this to go through an executive decision to be adopted, even though we will emphasise what we're doing there is not adopting it just for the council, it is very much for the city. So what we've got to within the strategy, and I'll just quickly start referring to that, is a bit of an explanation of what I've gone through so far about how it's produced. And then there is a page which talks about our vision and the 3 pillars. We try to get the language right in the strategy, probably don't always get it right. But one thing I've been very keen to do is to not set promises that can't be delivered, and actually just to keep things quite plain and simple. And we've gone with, at this stage, the idea we want to create a society that works for autistic people and people with ADHD in York. So it's a whole society approach that will encompass healthcare, but it goes beyond healthcare. And the 3 key pillars, the first one is about changing society for inclusion. So we want the city we live in, its schools, its businesses, public spaces and other settings to present no barriers whatsoever to autistic people and those with ADHD to live a full and flourishing life and to contribute to York. The second pillar is about making diagnosis and assessment work. So we want the policies, pathways and stages of getting an autism or ADHD assessment to be clear, to be well understood by professionals, to be equitable and just and as timely as possible. And then the third is around improving support in every setting. So ensuring there are better support offers for autistic people, those with ADHD in every sphere of life, that professionals are responsive to need, and support and adjustments aren't dependent on diagnosis. So there's a number of key points there. Not needing a diagnosis for support to be present, making sure that processes are equitable, and where we can't, as statutory partners, always deliver things immediately within timescales that may really appear reasonable because of the funding situations we find ourselves in, we can at least communicate about that clearly. We can at least be honest with people. We can make sure that we don't lead people down a particular understanding that actually isn't true. A number of things that we feel we need to do as a partnership. And then, of course, the societal things which go beyond merely health and care. So I won't go then through the 3 pillars in detail, but each 3 pillar is laid out with 2 columns, essentially. We heard, these were the things people told us when we went out to the groups, and then we will. There is more that can go in the we will column, and part of the next few months is to make sure we've got that right, and if there's anything missing, we'll add it. But we've worked with a number of partners to get sometimes quite modest, sometimes large, sometimes we might want to go further. Let's see what we can do type actions about changing society, changing assessment and diagnosis, and changing the support that's offered before and after, even if you don't actually end up having a diagnosis or seeking a diagnosis or assessment. Towards the end, we are continuing to work on how we'll know we've made a difference, how we measure these things, and we actually want people to tell us what that would look like. So that is, as you will see, a blank page at the moment, and that will be filled in as we go through the process. And then there is something about where this then sits. You'll know from my title and the other times I've been to the board, I'm Director of Public Health. Public Health actually doesn't commission or supply any services that directly meet the needs of people who are autistic or have ADHD, particularly within the adult sphere. That's slightly not true, I guess, within our 0 to 19s offer for children. However, we're not the predominant partner. There are other partners around the table who do provide those services, but as been said, this has got to be whole city. So actually, how do we make sure we follow through on it? Do we need a board of partnership? Do we need regular public meetings? Do we need an action plan and a set of indicators, or is that not very helpful? All of those questions, just to almost anticipate some of what committee may feed back, I think are still up for debate. So really hoping tonight's meeting can really help us possibly get to some answers for those things and help us along that journey. Chair, if it's okay, I'll just turn to my colleagues to, if there's anything that I haven't said or said wrong that they'd like to correct at this stage, or if anyone wants to cover any additional things, and then we can, I'm sure, go to questions. But anything anyone wants to add at this stage? Jodie, would you quickly like to talk a bit about the co-production in the next couple of months? Thank you.
Thanks, Peter. So Peter mentioned Dr. Laura Fox, who works at the University of York, who's helped with the HNA, and she's been on the working group for the strategy. And she's really kindly offered some additional support over summer. She's got a lot of experience in doing really effective co-production that ensures it's really accessible, particularly for this community. So Laura's primed to go out to the groups we've already worked with, just to see where are the voices that we're not reaching. There's some gaps you'll see at the back of the document that are in blue around children and young people. We want to do a bit more in-person engagement with some children and young people groups. And she's also going to think about designing some in-person events for adults that aren't in sort of council health buildings, in places that people are going to feel able to come and contribute, and sort of come up with a range of methods that people can feed in to us on that. So we're going to start to plan those next week, in fact, when she comes back from some annual leave. And we're really confident that she'll have some well-designed events planned which will feed into this. And then alongside that, we're planning sort of a public consultation as well. Again, just making sure that's really well designed and getting disseminated to the right places, just to get as much opportunity for feedback as we can, to just make those final amends before final publication.
Okay. Anybody else from your, we're very, Victoria.
Hello, just from thinking about the 0 to 25 special educational needs and disability area. At the same time, and it's relevant, we are also co-producing our send and alternative provision strategy, and that's very much linked to the strategy we have here. So anything that we're doing in this space at the moment between now and the October Executive Board will feed into the work here as well. And I think that's really important that we capture aspects of that co-production as well.
Yeah, sure.
Thank you. Just to add more to co-production, and from kind of adult social care perspective as well, we will also be working closely with partners and linking our preparing for adulthood kind of review of current processes and what's happening in that area. So we will be linking everything into so it makes sense, but equally acknowledging that it's about people's journeys. When children are children, isn't it? They're going through the journeys, and most cases, children are experiencing all of those things. So it's just really making sure that it's all in the same kind of space, and we all communicate with each other. So it's happening.
Yeah, thank you. I don't know if you want to speak, or you're okay. Thanks very much. Really, thank you very much indeed for coming along. So I'm just going to open it up for questions. Okay, and yeah. Okay. And I also should mention that Councillor Steels-Walshaw is here as the executive member covering this area. I can't remember your full title. I don't know. But I'm sure.
Executive Member for Health, Wellbeing and Adult Social Care.
There we are. That. Thank you very much. So Councillor Rose, and then Councillor Penton.
Yeah, nobody will be surprised that I've got lots of different things, but I'll give kind of overarching stuff first, if that's all right. Obviously, I talked to a lot of the usual people, various members of the community, other neurodivergent people that I knew about this, and to try to get some input from them. And thank you, by the way, to Roger for the comments under public participation. I think just off the back of that trauma conversation, it's really important to hear that personal perspective, but also not just the experiences of being autistic, but then the trauma of losing your home, losing your job, divorce, etc., and how that kind of compounds this. The response rate was much lower this time round. In general, people were feeling really fatigued at talking about it and dealing with it. There was a sense of burnout around the topic at large. I guess that's partly because the challenge is not much, it's still as big as it always has been. There's a little bit of kind of the stress of continuing to talk about it. But those who did chat with me, pretty universally said this report, the health needs assessment strategy, was like night and day to what we've had before. They said hugely positive things about what we've got in the docs today. The report is really clear about what stage we're at, what engagement with the public has already happened, what it is expected going forwards. The language in the report is much better, demonstrates a better understanding of how people generally prefer being described, identity first, etc. Particularly people liked that, as well as recognising the societal disabling factors and legal equality aspects. It didn't describe thinking differently as an illness or disability, because that's how they feel the ICB still sees it, and a lot of healthcare organisations as well, and a lot of their experiences on a day-to-day. They also said listing exercises with over 20 organisations is really, really good, considering the limited resources. And I'm pleased that's called out in the strategy as well as in here. And I agree with all those points. I think it is really, really good. One very brief overarching point, and all my other points are kind of related to paragraphs, if you like, is the neurodiversity aspect. So the documents recognise it. It talks about neurodiversity, meaning people who think differently to this kind of specific point that's seen as typical. I guess the definition varies on how broad from that centre typical is counted. But for instance, autism and ADHD, the trauma agenda item, PTSD and EUPD, dyslexia, dyspraxia, dyscalculia, Tourette's, syesthesia, echolalia, aphasia, schizophrenia, stammering, epilepsy, OCD, anxiety disorders, but also some cultures in York have a more blunt way of speaking. Some languages think of time in a different way. Some people are more or less logical, feel too much or too little. Recently on the internet, well, over the last few years, we've had the blue, black, white, gold dress, the Yanni Laurel thing, how people visualize apples. Like, people's brains work differently to each other. And so I guess there's a piece of, I've said before, it'd be good to have more about that in there, but I actually think a more important point is how the contents of this strategy and the action plan will improve things for all those different groups, not just by being mindful of that, but also because of the intersectionality of the different groups there. And a last point on that, I guess, is neurotypicals also find scenarios that are less easy for them than people with autism and ADHD. The pandemic lockdowns were one example where different people found it more thriving or challenging. Engaging with AI is another one, I think, that neurodivergent people sometimes find slightly easier. So again, that considering meeting the individual needs, that supporting everyone, actually makes a universal service improvement for everyone, whether they're neurodivergent or not. So yeah, I guess this isn't a neurodivergent strategy per se, and it kind of explains how it is and isn't. But I just wanted to make that really good point that a few people had said to me that actually this benefits everybody. It's similar to talking about the trauma-informed bit of, if you meet people and their individual needs, then it benefits everyone. So I've got, not everything's as positive as that. There's some improvements we made, but overarching, I think that was the big response that I got back from everybody I talked to, was having seen what came through before, this is a really, really good place to be right now.
Yeah. Well, and like you say, night and day, and it's great. And I'm really glad that the last time you came before the committee, that you met Dr. Fox, and that you could start that collaboration. And I just know, as a disabled person, we always say nothing about us without us. And I think it's great when experts start to look into an area, but when you include people who have whatever disability, things start to improve dramatically usually, because once you're involved, things do usually get better. So and as I said, we've had very positive feedback on this. So sorry, next is Councillor Benton. Thank you.
Thank you, Chair, and thank you for the report. I suppose my comments are really around sort of framing in terms of how you kind of anchor the strategy in terms of what's going on. So we know that the key themes are acute community, the importance of neighbourhoods, the neighbourhood approach to health, social care, other support services. So it might be worth trying to weave some of that into the strategy, because there's some good stuff in around sort of peer groups, community-led groups. I think in terms of trying to anchor the strategy to, frankly, things that are likely to attract some funding, because there's a lot of good stuff in here, and there's talks about using funding pots. But I think in terms of raising the profile of this, in order to be front and centre when there is prioritisation going on, as inevitably there will be, having this as front and centre, not as a, oh yes, we've got a strategy on that. Wouldn't it be nice to make mention of it, to put this strategy at the centre of those conversations? And that's maybe more around framing than the content. But that was, yeah, just an initial sort of thought I had from reading it.
Do you want to come back on now? You're okay with that?
Well, just to thank Councillor Fenton for the comments, and I think Councillor Rose too. I think the issue around funding is a really important one. It's elephants in rooms, etc., that I think we would all acknowledge that if the NHS's budget for assessment and diagnosis could double within this area, waiting times would reduce, and it wouldn't solve everything, but it would significantly help. We know we don't have access to those kind of resources, nor in some council support areas are we able to suddenly double budgets. But Councillor Fenton is exactly right that I think, particularly within the societal adaptation of this, actually, and we now have a mayor, we now have a combined authority, we now have funding streams through devolution, and I think we need to be thinking really creatively. There are pots around businesses and how businesses adapt. It's really important to make the emphasis there that actually a society which works for those who are neurodivergent is probably a society which prospers even further, because at the moment, essentially what we're doing is holding people back from economic productivity, holding people back from inclusion, and we're not benefiting from that as a society. So actually, interestingly, a strategy which probably comes to a health committee, it feels quite health-based. There are parts of this which are about how do we engage with pots of money around economic growth, pots of money around transport, that sort of thing. So it's a great point. I'll take that back and have a conversation with our economic team about that.
Okay, that's great. Councillor Steels-Walsh, did you have your hand up earlier? Mike.
Sorry. I just wanted to make some comments and some observations on this. Really pleased to see this report coming through. I was really pleased of all the collaboration that had taken place, and that things were included that had been discussed at the last meeting, and the working with Dr. Fox. I think a major theme, and it was heard from Roger when he spoke earlier as well, is creating a society, a place where people with neurodiversity are accepted and things are there in order for them to be able to live in that society. Really interested in hearing how more that can work through education. I think a lot of it, some of it in there reflects changing attitudes as well. I was speaking to Peter recently about the substance use, the drug and alcohol. Absolutely shocking that 28% of people with a neurodiversity may have a substance use problem, really, and also the levels within substance misuse are likely to be pretty low, because these are multiply excluded people who are less likely to be involved with services across the board. And I think that now working with the substance use services within that shows a will to work with multiply excluded people going forwards, and looking at how we do this further, working with marginalised groups who are less heard within this and more likely to have their views missed. But I think the report is really good and really taking into account people whose voices we do need to hear and are included. Thank you.
Thank you very much. Councillor Runciman, then Councillor Wilson.
Two questions, but they're two very different ones, Chair, so I'll ask them separately if I may.
Sure.
The issue that always interests me is transitions. And it's very interesting to see the team that you've brought with you today from all the different services. But I would like to hear from somebody about going out of CAMS and into adult services, and how how that can be managed better than it has been in the past. And I think I can safely say that there have been occasions where it hasn't been managed very well. So I don't know who'd like to pick that one up before I ask a completely different question.
I will answer that. So I think what we again looking at is what can we do differently, because we know what has happened, we know what's been going on, and actually has it worked or has it not worked. And so what's happening now in terms of the transitions and how we engage earlier with those children who have who definitely would require that ongoing intervention, statutory intervention from adult social services. So we're doing a lot of work around, and I'm talking from the adult social care perspective. We're doing a lot of collaborative work now, starting very early on with children's social care and supporting children's social workers into that preparation for adulthood journey, which also includes strengths-based approaches, looking at the kind of person-centered interventions, looking at the individual strengths, also taking into account, obviously, their needs and what is required for them to live healthy and happy lives. So we've started that piece of work now. So we're just kind of expecting that there will be a lot more changes, and we will, and in order for us to kind of evidence or even see those changes, I'm very interested in understanding people's feedback and experiences. And again, as part of this group, what we've done is engaging with the community and understanding what's happening for them. What else can we do? So that's, in terms of the transitions, that's how adult social care kind of looking into what we can do slightly different at this point. And I think there is also obviously a strong awareness around, you know, how are we aware of and how we support autistic individuals. So it's just raising that, continue to raise that awareness and training of staff and the kind of community as well. So I can just kind of say it's still ongoing, and we'll just need a little bit of time to start evidencing positives. I hope that answers your question.
I'm really pleased to hear, Chair, that it's on the agenda and high up. That's very good. Can I ask my second question? Yes, thank you. This comes out of something that Roger said. He didn't emphasize it too much, but I would guess he had a bit of a battle royal to get his diagnosis. Do we have room in the system for late diagnosis? Because most of what we hear is not about people of Roger's age, without wanting to be rude at all to Roger. It's about younger people. So I don't know who can answer that one, but can we do that? Is it possible?
The adult service, I guess, is inclusive for all age. So actually it's open to anybody over 18 to be referred into that service. And there isn't any prioritisation criteria based on age. It's based on circumstance. So I guess the easy answer is it's inclusive to all. However, I guess what we do know is the demand far outstrips the capacity that we've got in the system. So I guess the waiting time would be equitable for all. So it doesn't, I guess, discriminate based on age, but you know, we know it's less than ideal.
Yes, I think you don't mind here. We like to be helpful.
This is a school one. do schools feel they have to wait for a diagnosis, or do they put help in when they realise that there's a problem and that the child or young person needs help?
Schools, the aim is that schools are meeting the needs of children and young people at the earliest opportunity. So that's set out in our code of practice in the Children and Families Act around a graduated approach. And that remains our strategy in York, to look at supporting inclusive mainstream schools. And that's how our services are set up to wrap around schools to help them with that. So we've got specialist teachers, we've got educational psychologists, we've got our schools on board with that. That area of inclusive mainstream school is massive in the national context at the moment. We know the drive around that, and that will remain a big focus for us in York. So they're a big part of our SEN system to support those children and young people who may not yet have a diagnosis, but who clearly have needs. So meeting need is very much about where we're focusing the attention, not waiting for a diagnosis, but that's why the partnership work is so important.
That's good. I'm glad to hear it said. Thank you.
Thank you very much. Thank you. And Councillor Wilson.
Thank you, Chair. I will just slightly refer back to that point, having experienced it as a parent, in that until there's a diagnosis, you are not allowed to have any changes made because schools are so overworked at the moment. But my point was then going to be, so my question was then around you're listening to the schools having unhelpful behaviour policies and the accountability, and the fact that I know from my own personal experience and sort of people I've met through the home educating community in York, is that there's a lot of home educating going on because this isn't happening. And I just read your bit saying about education settings and the SEND partnership training, and I thought maybe you're missing the home educating community, because often that's when it's too late. We failed at this bit. And that's quite a big issue in York. And then you're in this weird gap where there isn't any support, both within the home educating community as a whole. And then there's also a disproportionate number of gypsy and traveller children that are in part of that as well, because they tend to be taken out of school. So it was just to raise that point particularly. And I had another point and it's gone because I was responding to that on a more personal note. I'll raise that. Oh, my other point was going to be how your, I know, Peter, you mentioned the connections with working with young people with autism and going out and reach them. And I know, again, personally, and through some of the work that I do, that is quite hard. I didn't know whether you've got some sort of strategies for where you're going. There's some organisations in York doing amazing work. So Kyra, for example, have an 18 to 24 group for women, and there are a very large number of people who are neurodiverse in that group. It's known as being really successful, so successful that they're now doing a Steps to Rose group for people who are unable to access it because it's got so big and popular and are struggling with it. So there's lots of good stuff out there, and I just wondered if you knew about them and were tapping into those sorts of groups as well.
Thank you. Kyra is definitely one that's on the list, but I think it's like everything. Everybody knows something that someone else doesn't know. So I think if there's some really strong ideas or suggestions or feelings about groups that you'd want to make sure we contacted over summer, then please just email us. Laura's developed a good list. We've got a list as well already, but you know, we don't know it all. We don't pretend to. So please just contact us if you think of any others. Thank you.
And Chair, if I may just add that very much take the point around children not educated in a school setting, home education. Absolutely, I think we need to include stuff so we can work on that. And I think there is something about Councillor Rose's point about actually this time around, not as many responses because people do feel quite burnt out and tired about having to respond to things. And we're trying to sensitively work our way through that because we do absolutely want involvement within this. But we are aware there has been a lot of disappointment about the way things have gone for people who are neurodivergent in York over the last few years. We've got a journey to build up back some of that trust. That's why we are trying in to not overpromise within this and trying to make this as honest a document as it can possibly be and over deliver, so people then do build up the trust in the statutory agency so they can feel more able to contribute and be part of these types of co-production things where they feel listened to and actually that we'll do something about it. So it is a bit of a journey in that regard, but we will make those links, as Jodie said, to the organisations.
Thank you, Councillor Baxter.
Thank you, Chair. Just on the section about ADHD and gender, obviously it's noted that boys are more likely to be diagnosed with ADHD than girls. I just wondered, because it's sort of widely accepted that girls are more likely to mask with these sort of symptoms. Do you, I mean, I don't know if you know, do you think that it is that boys are more likely to have ADHD, or is it that girls are able to mask more so than boys? And what is being done to look at when diagnosing boys or girls? Are there things that you're supposed to look out for in girls that you can realise, or maybe they're masking? And sort of, is there any difference there when looking at boys and girls when diagnosing these sort of things, and what are teachers equipped to think about that, to look at that? Because I feel like that's sort of more of a recent thing that's sort of been acknowledged and looked into. Thank you.
I think it's a really, really important question, and I think that the gender differentials within this are just massive in the ratio, so you in any way can't ignore it. I fear it may be a question that goes beyond the expertise of definitely me, possibly others on around the table. I guess what I probably would say is that I think there will be a need to understand and to be aware. And I think our previous item, the phrase that was used a number of times, is a really important phrase within children's social care, within safeguarding, a lot of those different sort of spheres, is just professional curiosity, actually. It's just actually people being even aware that girls are more likely to mask and to be underdiagnosed. Therefore, within an overall holistic assessment of a child's needs and the way we might look to support them in the classroom, those factors need to be part of any care planning, EHCP, whatever the process is. I can't comment exactly on what a clinician doing the diagnosis would look to incorporate within their sort of diagnostic approach, because I guess that, yeah, that's probably more for someone working for the treat or for CAMS to put into. And we can certainly look into if there are aspects within this in terms of you know, female and male ratios in the strategy. Is there more we can say actually about that? Is there other things we need to get better in our communications, the local offer website or Raise York or the various different information sources referenced? Do we need to just be a bit more obvious about saying those things so professionals are aware when they read them that they might want to look a bit closer?
Any more questions, Councillor Rose?
Yeah, just a few. I'll pick all of my health needs assessment ones, and then I can leave the strategy ones if anybody else has got things to not have me talking all the time. The first bit then on the exec strategy kind of boxes, we've already mentioned, Roger mentioned about the kind of prevalence piece, and I've emailed through about that. But in terms of the waiting times, and Carol, always ask questions and have as much input as you like from my perspective. But coming back to that question, the assessment waiting times listed here were 5 years at the time, but then obviously we split into basically critical cases are the only ones that have a diagnosis pathway. It's now 3.7 years, so I guess to some extent it's working, at least in bringing down the time frame for those. But the waiting time for those non-critical cases is still infinity, being blunt. So I guess the main question is there any news or sign that's changing? And just to kind of pick into that slightly, in chapter 1 it talks about the holding list. I've previously said it's more of a wait pit than a wait list. The number of people in that pit must be massive. Now I can't find any public numbers on this properly. In the last Humber Teaching NHS Foundation Trust Board papers, there was a report from the Humber and North Yorkshire Health and Care Partnership, Mental Health, Learning Disabilities and Autism Collective. That's too many words. We need to sort on all of these. Said there were 23,000 people in the region in that wait list at the moment who are, as things stand, and obviously that's not just York, but they're never going to get a diagnosis as things stand. So 80% of them presumably will receive a positive diagnosis based on the evidence in the paper here. That same report flags East Riding doesn't have an adult ADHD assessment service. North Lincolnshire doesn't have an adult autism assessment service. So it's not just us. This is a pervasive issue. But those 20% probably should be on another waiting list somewhere else. It's much shorter to get diagnosed with some other thing that's causing the challenges they're facing. So just in general, what numbers do we have, if we have any? What are we looking at in terms of the solution for the people who are stuck there with zero chance of getting a diagnosis as things stand?
So I can answer from, I guess, the collaborative, so across Humber and North Yorkshire, and then Angie can be a bit more probably around specific to York. So there is another paper due to go to the very long-winded collaborative exec board in June that provides an update in terms of the numbers. And as you say, it's into the thousands in terms of those that are waiting. There is a proposal going around, and I guess at the moment I probably can't share the numbers in terms of what it would take to clear the waiting lists for the 0 to 5s, the 5 to 18, 18 plus, in terms of clearing that, both the backlog and then what would be needed recurrently to go through. And we are talking in the 20 millions of what would be needed, I guess, recurrently to manage the demand that's currently coming through the system. Humber and North Yorkshire across, just for I guess context, spend about 7.5 million in core commission services around assessment and diagnosis, and then a further 3.5 to 4 million on right to choose. So that's where people choose to go elsewhere. So I guess it shows the gap between what we've got and what we need in terms of taking that forward. There are some discussions ongoing around, actually, if you look more around the needs-based approach, so because it's very much a diagnosis approach, isn't it? And what it doesn't look at is, well, how do you support people? So once they've got a diagnosis, there's bits sometimes about so what. So actually, does somebody need a diagnosis to get some of that support? And could we do things differently? So there has been a lot of work done to validate the numbers, and they change all the time. And I think included in that report, it basically says at the moment across Humber and North Yorkshire, there is the waiting list goes up for adults circa 150 every month. For children, I think it's 500. It shows the scale of the gap that we've got at the moment, that I guess we haven't got the resources to try and reduce. Hence why I guess that it's only ever that 20%, isn't it, that are on the waiting list post triage, certainly in York anyway. So I'm sure when it's been to the board in June, then that report can be shared, and I guess the numbers can be shared to be public then.
Yeah, and I think those numbers would be good on the exec summary if to show the scale of unmet need in people waiting. I mean, that obviously excludes anyone who decided not to bother going for diagnosis at all. I mean, I'm ADHD but not diagnosed. I know I won't get diagnosed, full stop. So I don't want to drain the resources further by putting myself on a list for no reason.
Who have been referred.
Exactly. And as a side point, it is illegal to hold back reasonable adjustments without a diagnosis. So it's worth a longer conversation at the time, I think, about what else we can do on that across the city. Picking through the HNA points, there's a lot in here about children and about adults, but there's not much in the HNA around that migration from children into adults. And I think there are health needs that are related to that, but also that transition is causing health needs because of let's say how not smoothly the transition goes for the majority of people that go through that. The definitions piece, I think it is really good to identify here, explain that the community isn't a monolith that just has one way of being referred, that medicalized identity first language piece, I think is important. The one thing I think that's missing from that is there's no definition for learning disability. Later on, it says there's a 70% overlap with learning disability. In the definition section, it says learning disabilities aren't a form of neurodiversity, which I would personally disagree with, but defer to the experts on that. But I think a clarity of what we mean by learning difficulties, I think, or learning disabilities, I think would be a useful add. Nobody I talked to raised this as a concern with me, but I still have a concern around the causes bit. I think that it's a weird way of looking at it and talking about it. That, I mean, the causes are genetics and epigenetics, right? It's not like trauma that has events triggering for the most part. But then life factors can exacerbate the effects or can change kind of how it plays out. So I just think there probably is a better way of phrasing that, but no real suggestions other than it just kind of, every time I read it, it just makes me feel a bit odd. And then in terms of some of the needs in the HNA specifically, I mean, 13 years lower life expectancy for autistic women with a learning disability is, you know, puts it into perspective, doesn't it? The link between homelessness and autism is one part of that, and again, we've heard an example of that tonight, that isn't on the critical list of things that triggers the diagnosis. So people that are going through that aren't even going to be on that diagnosis pathway for the most part. So I guess a question on that would be, should homelessness be added to the list of critical triggers, and is there more we can do to support the homelessness team in having access to the right information or training supporting that? And then same further down in the ADHD section with heavy alcohol use, early dementia, can things like that be on the critical thresholds list? Can we, you know, find a slightly balanced way of showing that people do have significant needs and it is having a massive impact on their life and their health, and they can't just be sat there with no diagnosis indefinitely? Some people can cope, but some people are struggling more than others. That's kind of my H&A bit. I've got another half of my questions, but they're all strategy side.
You've got strategies that you're offering?
No, those are all questions and comments on the paper other than Appendix B.
Okay.
So I've got all my Appendix B questions remaining, Jane, is what I mean, sorry.
Okay. Do you want to come back on that before we go on to Appendix B?
On the exception, so people can still get referred in by exception outside of the criteria. And I think it's that some of those are really hard to quantify, and that's what we found with the referral form that we've got to now, that's been through 4 or 5 different peer review groups, and we've got to a stage where we've defined criteria that we can kind of let GPs make a decision on, but over and above that, referrals can be made into the specialist service by exception. That would be their clinical judgment of whether that needs an assessment.
Just a follow-up on that. Is there any chance you could give us some, not here now, but like play through in due course, some examples of what sort of things have been on that list, just so that there is more awareness that can happen? Because I think, A, most people don't know it can happen, and B, I don't know what the circumstances are if there are any. So whether, you know, how significant you have to be in trouble.
I think that's, but as an ICB, we can't put down on a piece of paper, this is the circumstance where you would qualify for an assessment. That's why our specialist providers have kind of got their own criteria that they could work through, and they would probably have to have an initial triage assessment with that individual to. Yeah,
just if there's any tangible examples that have happened, that would be useful.
Yeah, I think we have got some examples from when we were pulling the referral together. So yeah, certainly. Yeah.
Okay. It's great. Annex B, I think you're you're doing a grand job.
Okay, well, I hope nobody's got anywhere to be. Strategy. Number one, it's really, really good. I think the layout's really good, the format's really good. I think it's strong in themes. I think it's well worded throughout. I think it represents the community sentiments really well. I think the actions, there's lots of really good ones there. I think if they can be delivered, I think it looks really good. So the main bullet point that I found it surprising there's no mention of CHUV in the entire doc. I thought they'd be in Pillar 3 and the appendix. Adult mental health service is obviously a key part of this. And one of the key challenges, I think, in building up that trust and ditto building up the trust with the ICB, I think there's a piece around that, and CHUV missing is a surprise for me. There's a seemingly large issue around people having to choose which part of themselves they want support with. So, you know, gender, neurodiversity, other facets, comorbidities, that people having to seek support for one bit, and then eventually once they get through that, they then pick the next thing to go through. And I think there'll be people who know they're on this massively long waiting list, and so they just kind of abandon any neurodiversity support to try and get focus on anything they can get that's more tangible. It's kind of reflected a bit in this, but there's not really much in how we tackle that challenge. To use council speak, there's good mentions of place but not movement. You mentioned kind of transport budgets earlier, but transport networks, public transport, narrow pavements in congested areas, crossing points. We had a whole conversation with the neurodivergent community around city centre vehicles when we're looking at blue badge ban situation, delivery vehicles, etc., and that kind of noise and social anxiety piece around the city centre. I know it mentions the Christmas market, but in general, some of that stuff around getting to and from places, I think would welcome an addition. I think that, I mean, there's no excuse for the school behaviour charters piece anyway. There's formal training. I mean, all teachers should be up to speed on this. We need to really work on that. I don't think there's any excuse for anybody to not know this stuff better in that space. But how we tackle poor understanding and stigma in the general population, particularly parents and other kids in schools next door neighbours, where we get casework and, you know, we see a lot of those challenges that people experience are because people don't understand them, that they deal with on a day-to-day basis. I think that's a challenge identified in here, but there's not an action that really says how we reach out into those individuals and communities. I'd be interested to know on page 90, pillar 1, about the Christmas market. Obviously, the stadium sports stuff, they've got a kind of neurodivergent corner or a quiet corner that kind of caters to that, but the Christmas market, there's no equivalent to that. So when they've been suggesting that, is that more of a spread it out across the city, or have an alternative quiet Christmas market, or, you know, reduce the crowd? So like, what is it they're thinking? Would be something I'd be interested in knowing, and ditto for any other events. How do we reduce that? I can pause, or I can just keep whittling through them if people want me to.
Shall we have a pause there?
Okay,
Just
yes.
so we can, yeah.
I'm happy to respond to some of those, Chair, and others might want to as well. Really helpful, because there's lots of things we can incorporate in. We've talked about TUBE, but it has predominantly focused on CAMS, so I think we need to pull in the AMHT dimension to this and understand the adult mental health bit and how that fits. So we'll go to TUBE and ask them to do it. Just to clarify, quite a lot of this has involved asking partners for contributions, and part of that is a bit of an ongoing process as well, so we can keep on doing that. Absolutely around transport, and we haven't talked about sort of buses in here, have we, and pavements and that sort of thing. I think the Christmas market is an interesting one, because it was raised by a lot of people as a very, very loud, noisy, crowded, overstimulating environment. Obviously, we know that, you know, the Christmas market brings huge benefits to the city, and is, you know, an important plank of, you know, some of our hospitality tourism sort of strategies. So there is that balance about how you might make any reasonable changes there when what is a large scale outside event. I think the only answer is that we're at a very early stage of exploring that. Make It York obviously have the responsibility for organising that, and as a partner, not as part of the council, because they're arm's length. I think we'd have to go to them to ask those questions, but there are always innovative and creative ways of doing these things, and there will be people in that organisation and traders themselves who are neurodivergent, and I think there's probably something about, actually, we don't have the solution yet. We need to ask the community, and we need to ask traders and people who might have stalls what could be done there, and it may be that there is a small segment that is quieter, that doesn't have as many sort of sensory overload. It may be that it needs to spread out a little bit. So we'll very happy to come back to committee and update on those conversations. But I would love to put a plan before you this evening on that, but we don't have it.
I do happen to know that that they have a quiet space in St Sampson Centre as well. But that's a very different thing to going away from. I mean, I just find it really overwhelming, and I don't think I am neurodiverse, but so I can't imagine what it would be like. It wouldn't be a place I'd want to go, to be honest. I don't want to go. With my little thing, I think I'd be flung out. But anyway, sorry.
It's okay, I was just going to comment on the TUBE bit. So I think we can help with that, because obviously we work really closely with TUBE, especially in adults and children's services, and there's a lot of work around inclusion within all services for people who are neurodiverse, and there's obviously a lot of training ongoing within TUBE. So yeah, if we can help with some of that, because there's probably quite a lot they could contribute.
Thanks. I mean, I guess on the tube piece, I was thinking about it as a partner in general, as well as you know, as a totality. We've got the York Hospital and stuff on here, so I think it was obviously they're directly involved in the assessment services and mental health from that perspective, but broader health service, I think, as well. And yes, the Christmas market. I think part of the problem is that, and something we need to think about is, what is it that people need to go there for? You know, if you don't like the Christmas market, don't go, right? But all banks are pretty much within a 50-metre distance now in York of the Christmas market. You know, we've got a banking hub in Acomb now, thankfully. And, you know, there are a couple of banks that are slightly further out, but I think it's things like that and understanding what it is that people need to engage with that is difficult. At least I don't think it will be easy to make the Christmas market quieter, even by growing it geographically. Page 91, there's some stuff around the business charter, but there's a businesses and inclusive schemes bit that doesn't reference it, and the good business charter has an equalities and inclusivity aspect to it that I think is useful. Personally, I'd put that in place of the utilisation of the National Autistic Society accreditation. I know it was developed with the Autism Education Trust, but personally, I still have some issues with NAS that are not worth getting into now, but I think there are, from a business perspective, I think there are better schemes out there. Pillar 2, page 94. This did come from a lot of people and a quite significant level of concern around it. It looks like we're baking in the Do It profiler piece. Unanimous comments from every single person I spoke to is they still hate it. They still think it's terrible. Every single bit of feedback from day one has been, this is bad. Why aren't we going down a different avenue? And to be honest, a lot of people, one of the reasons they didn't want to come and talk and engage more is because they've lost I was going to say lost the will to live, but that's inappropriate. But they've lost the fight to tackle this because they feel like they've been ignored on this particular topic time and time again. And what we're hearing at this point is, well, we'll try and make some of the content available earlier, but the profiler is still a problem for many people for many reasons. And I still don't fully understand all of those reasons that it comes with that level of grief. But for a lot of people, that is still the biggest issue with these papers, alongside the kind of speed of diagnosis, if you like, or lack of diagnosis. Actually, it'd be good to pause there, and if anybody's got any thoughts on the Do It profiler, it's a big one.
I mean, the main thing is the Do It profiler at the moment is and will always be optional. It's not mandatory to anyone on the pathway, so it's an option for people that can't immediately get a referral for a triage for assessment. We've got, and I don't know the exact figures, so I don't want to quote, but we've got over 8,000 people currently using the Do It profiler, and the feedback response on it is that I think it's around 70%. I will check the figures and confirm them, but I think it was around 70% said they found it useful or very useful, and that's people pre-diagnosis. I think sometimes the feedback we're getting are people that are post-diagnosis that understand a lot more about their self and their traits already, probably don't see it as a useful tool because they already know a lot of it. Some of it is people that are waiting for assessment, especially if they're early on in the journey. They do find it useful because it is stuff that's new to them. So we're just working on the feedback we've got. And when you've got kind of over 80% of 8,000 people saying they're finding it useful, we're not going to get rid of it, but it's by no means kind of mandatory for anyone on the pathway. I guess that's the point.
I suppose just to add as well, I suppose just so you're aware, Hull and East Riding are looking to adopt the Do It profiler for a slightly different, I guess, purpose, but I think they are looking at it for children as well around some online support. So I guess it is being adopted in other areas as well across the ICB.
Yeah, I guess I think everybody who has an issue with the Do It profile is aware of that fact, and it's part of the concern. It isn't, autistic or ADHD people requesting the Do It profiler gets rolled out in these places. It's just being, imposed on them if they don't like it. And I think a lot of the people who have found it useful, they found the content useful. But my question still remains, why don't we just make all the content public? I mean, I've been a line manager to neurodivergent people in the past, and me having any knowledge of their coping mechanisms, and I've worked with them on various different kind of personal plans. There are lots of different, York Mind and UK Mind and various others have lots of personal plans that support it. Knowing how they, what challenges they have and what barriers they overcome and what they do to mitigate helps me remove a lot of that for them as a line manager. So, and as a parent, as a carer, as a friend, that information is really useful. Why we're locking it behind a kind of, not even a paywall, but a random tool, I don't know. And I think my experience of talking to people is that that's the positivity, is there's some useful stuff in there, but it's kind of buried in there, and I'm not sure why. So I think it's still worth revisiting whether there are better ways of doing the kind of profiler piece, or there are better ways of exposing that information and data. But I guess just raising that point is, in all of these strategies and current assessment, it looks like it's now a permanent fixture, and at no point has there been an acceptance by the community at large, I guess is how I'd say it. My last few bits and pieces. Page 95 mentions Raise York. It doesn't mention Live Well York. I think Live Well York is a really good resource, but it can be improved in this area. End of page 96 talks about making resource packs available. I just mentioned that I think it'd be useful to look at, who doesn't need to be diagnosed, but also who doesn't need to be going through that referral process to get access to it. Does it reduce the number of people in that waiting list if they know they can get access to stuff without asking for that diagnosis pathway? Should GPs be able to access it at the very least, or is there something we can do? End of page 97, again, that transition from teenage to adult support, I think, would be a useful block to add in. There's a bit there about children and young people, and some of the clarity around the care and needs they've got, I think, and the transition into adult support is useful. Pillar 3, I think there's not a huge amount about council service in there. I don't actually have any suggestions. It just feels like there's a bit of a gap there for what we can do better inside the council. And I think it's a little bit, lots of clusters of things in there. It's not structured very neatly. And I wonder if there's a way of clarifying it by looking at the beneficiaries of the action. So you've got the sort of passive support for the neurodivergent children and adults who can and want to support themselves. You've got the proactive support for neurodivergent children and adults who don't have carers or parents but struggle to support themselves. And then you've got the support for the parents, the carers of children, and support for parents, supporters, carers of adults. And they're all slightly different things, and they're covered by this, but it's quite hard to see which actions of which people, I think, if that makes sense. And the last question was just, there's a bunch of stuff in here around comms, and some of it's kind of healthcare comms, some of it's just in general council comms or whatever else, about how they're quite poor. But I was curious to know if you've got the information to hand, or from your experience with talking to people, whether that's poor in frequency, or whether it's poor in quality, or whether it's that people use, let's say, flowery, imprecise language in comms, and it could be more like factually specific, or what is the issue with comms in general? Is there something we can kind of immediately learn as a group in how we do comms?
I think you don't have to come back on all of that at this point.
And this is super helpful. This is absolutely why these
Yes.
conversations are so useful. And I've taken a note of many of those things, Councillor Rose. So just that last one then, I think communications came out as a theme through a lot of the co-production, a lot of the messages, and it was in a number of different ways. So it was communications where an agency or an organisation is trying to inform someone of something, or invite them to the next stage of a process. So text messages, letters, that sort of thing. And that's not necessarily to do with their neurodivergence. That could be invite them to routine screening or whatever it is. Actually, we take often a very long-winded and complicated way of explaining things, particularly, I guess, some aspects in which thinking about taking things literally and those sort of traits we might actually get wrong. And actually, we could just all do with having a bit of a filter on that kind of public communication thing. So that's, I guess, directly to people. And then the wider sort of communications within the sort of, press releases and council sort of, when it says things about things in the public domain, just being really good on language, really anti-stigma, that sort of thing. So that's another domain. A third domain would be information provision on websites, and you've already picked up, we need to talk about Live Well, but being really clear and having websites that are well designed, well laid out, people can navigate, information isn't duplicated. That horrible thing on websites where you feel you're on a loop, you click one thing and it directs you to another thing, you think, oh, but then it directs you back to the first thing. So there's lots of that came through. And then I think the final thing is just honesty around communication. So being able to tell people for instance, what a waiting list diagnosis and assessment process looks like, what to expect, And to be really clear, if this means you won't be added to the list, that it means you won't be added to a list, and these are the reasons why, rather than the circumstance that has been described by a number of people of just spending years of their life not realizing that they weren't in a process they thought they were in, etc. So there's a number of pieces around the communications. That's why actually communications probably is in all three pillars, and it really cuts through, because it felt a bit weird to have it in one box because it affects all bits of this. So we hope we try to get that right, but I absolutely agree that we could, particularly pillar 3, maybe just be a bit more concise and pull things together in a little bit of a coherent way. So we can work on that.
I think the point around the sort of knowing where you're at is a really key one, actually. And as I say, it came through a lot in the feedback that this is the first version of the report where they've read it and they go, oh, that's where we're at in this process, and this is what has happened and is going to happen. And we've had a lot of that in previous reports, but it hasn't read that way to the people who are reading from that community. And I think the number of people who think they're on a waiting list and they go, well, I haven't had an update in 2 years. And it's like, well, I hate to break it to you, but you're not going to get any update, or the update is you're exactly where you were at the start of this process. That kind of clarity piece actually in many ways brings people comfort. I don't know what the right phrasing is, but people knowing that they're in a bottomless pit of doom is better than thinking they're not, and finding out as time goes on that actually I've not moved forward. Why am I not moving forwards? Oh, I'm in the wrong queue, or I'm not in the right place. Or so yeah, I think that aspect of it is very something. Thanks.
And also as an observation, that there are other things that you can look at out there to support you whilst you're waiting. It's not, which is not ideal, and yet, as you said, that the diagnosis can be expedited in certain cases too. I suppose that would be through the GP or yeah. So yeah. So to summarise, because I think we've covered this really well, and I'm sure it's been helpful. I don't mean that in a conceited way, but I think you've had some really good input from everyone this evening. Starting with the transition from CAMS to adulthood, adult diagnosis, and the demands outstripping this, these waiting lists that are phenomenal, but being honest about them. I can't help thinking as well, it's always down to funding, isn't it? That, groups that could support people in the meantime, they can, I know I belong to Facebook groups to do with my disability, that actually they're not experts necessarily, but there are other people with the same thing, and they can be really, really helpful because they can offer you, I don't know that we should be selling Facebook, but that sort of thing, or whatever alternative there is out there, Blue Sky, or I don't know. So yeah, and the issue about home education was, and the fact that people are doing that because they can't cope within the school system, I think is really a great point. I think we've just had so many really good points here, and you can always listen to the webcast again if you've missed anything, which is the great thing about this. So I think that we can draw this to a close now, and I do hope that you found that helpful. And it's very impressive having so many of you here to come along. So thank you very much, and thank you for all the members' contributions. Thank you. Yes. Thank you, Tim. So we're going to go to the work plan now, which is item 7 on the agenda. And I think a special thanks to Councillor Rose on that item, but not discounting anybody else's contribution. Right, so right at the back of our papers, we've got the work plan. I had a word with James about this earlier, and we kind of felt that the work plan as it is here is looking quite healthy and good. It's not overloading us, so that by the time we get to item 14 on the agenda, we're thinking, I think, given that we're a committee that deals with health and people, it's quite good to note our own well-being and health and our efficiency. So unless anybody has any particular comments on the work plan, I think we're going to stick with what we've got here. And we may move things about, but we will do that with the collaboration of other people. Councillor Benton.
Just without wanting to preempt the decision of annual council tomorrow in terms of new scrutiny arrangements, it would be useful for the new committee. Obviously, this committee will merge with bits of children's communities and young people. But by all means, keep these some really important topics to think about. Where are we informing a decision or contributing to policy development? Where are we receiving an update, which may lead to a formal meeting or a task and finish group? So my plea to this and all lots of other the other scrutiny committees is to think about how you want to progress those items in the new world of the new world of scrutiny, or whatever we call it, so it's less confrontational for outside visitors.
I think it's been a bit fascinating this evening, the combination of this. I think, I mean, if ever there was an example of how important it is to scrutinise things, this last item. Look at the difference in the quality of the report that's come to us this time, and how much happier the community are with it. You know, it's a great benefit, I think, and it's like with the ICB and the pharmacies. They have changed their policy now so that they don't just look every 3 years at the situation. They're constantly now updating, and that's thanks to this committee. And I think we should pat ourselves on the back for the you know, what we can change and what we have changed. And so I think this is the last committee in this format, and I think everyone, just a huge thank you to everybody and their contributions to it, and we can change people's lives for the better, which is why we're all here after all. So yes, thank you. There is no urgent business. So unless anybody's got anything dramatic, I think we can call this meeting to a close, and thanks everybody very, very much indeed. Thank you.